Assalamu alaikum, everybody. I must thank Yasser and Umar Bhatt for inviting me here. I just talking to Umar that he's making our life difficult because to organize a meeting of such a high caliber, he's sort of taking a very high standard for us. Now I'll be talking about graft fixation techniques and what's vital. Now we all know that success of our ACL surgery basically depends upon the patient selection, the surgical technique, but the most important thing, one of the most important thing is fixation. And if you go to his noise original paper, so what he stipulated was that for normal everyday activity, you need at least 400, and the ACL should be able to withstand a force of about 445, 445 newtons. And for strenuous activity, you are talking somewhere in between about 1,000 newtons. So anything you do has to withstand a force of at least 445 newtons if you're talking of activities of daily living. And if you look at the strength of the different grafts, we can actually see that all these grafts, even the peroneus longus, are far more than what we need. So out of all these, out of all this construct, fixation is probably the weakest link. Now we've got different sort of fixations starting from staples, cortical fixation, interference screws, rigid fix, and things like that. Now, so what should ideal fixation be? The ideal fixation, it should be stiff enough to start early mobilization because we cannot immobilize these patients. It should be secure enough to resist slippage of the graft. It should be gentle enough to avoid graft damage. And again, it should be strong enough to avoid failure. But along with it, it should be biocompatible. The results should be reproducible. It should be ideally be MRI compliant and should not cause too much problems with the tunnel so that if a revision is needed, then it's easier. Now we should also realize that the fixation in the tibial interface is the weakest link out of this whole construct. And it is just because of the decreased bone density at the tibial site plus the line of pull. And then we also have to think about two types of tendons which are commonly used, or the patellar tendon grafts, and the soft tissue grafts, which are the quads graft, the hamstring, the peroneal, and the allografts. Now, when we're talking of fixation, basically we've got three types of fixation. We've got an aperture fixation, which is near the joint. Then we've got the cortical fixation, which is away from the joint. And somewhere in between, we've got the intertunnel fixation, the things like the graft fix and the. Now, the interfemoral side is the intrafix and the transfix. Now, I haven't got any experience with it, but they are mostly used by people who are doing a transtibial method, and especially in our country, is something which is not performed on a regular basis. The aperture fixation is mainly due to interference screws, and this is because of the sort of the friction or the force between the graft and your screw, because your screw is put alongside your graft. Now, the screws can be metallic, or they may be bioabsorbable, made of either PLA or PDLA, and nowadays they are also combined with osteoconductive ceramic constituents like the beta tricalcium phosphate or the hydroxyapatite. Now, generally speaking, these interference screws, depending upon the size, you are basically talking of maybe about, they are able to withstand maybe a force about 500 to 600 newtons. So that is probably enough for maybe activities of daily living, but may not be enough if you want to have you want to go on a rapid mobilization. Generally, they have got their own problems. One of the commonest problems which we face is the graft damage, unless and until, because in our country we have a lot of these locally made interference screws, which may not be that properly designed, and the foreign ones, they are expensive. The problem with the slippage of the graft damage, and if the bones are osteoporotic, then the fixation may not be that good. Again, if you are using the metal, the titanium ones, then they may not be that MRI compartment. The PEEK ones, they are easily fractured. And with the bioabsorbable, we have got problems like tissue breakdown and osteolysis, and sometimes you end up having sort of larger tunnels. Now, so what should we try to use? We look at the literature. There's a Cochrane study which was done in 2016, which basically, we basically looked at these and compared the biabsorbable versus the metallic interference screws. And what they said was that the clinical results may be the same, but what they reported was a higher complication rate with biabsorbable screws. The same was reported by Zhu as well. That was again a systemic review of about 14 RCTs. And although they did say that clinically there was no significant difference between these two, but the complication rate in biabsorbable screws were significantly higher, like things like graft ruptures, joint effusions, and infection in cases of the biabsorbable screws. The next type of fixation we get is the suspensory or the cortical fixations, and then we've got two types. The one is you can tighten, the other one is the fixed devices. The ultimate load failure, this is roughly between maybe about 1,000 or 1,100 newtons, things for the rigid loop, and then it's roughly about 900 to about 1,000 for an ACL tight rope. So in comparison, we can see that they are able to withstand far larger forces as compared to the interference screws, roughly maybe about double. But then also you got a problems with them as well. The one is the bungee effect, because the problem is that what happens is because these grafts, which are, well, they are the soft tissue grafts, plus there is some stretch in the whole construct as well. So there is sort of linear displacement. And any linear displacement is more than sort of continuous linear displacement, which is more than 3 to 4 millimeter, you can end up having a graft failure. And then the second one is the wind viper effect, and actually the graft moves interiorly and posteriorly, and what you end up is having a larger bone tunnels, and that might cause problems, especially if you have to do a revision. Now, interestingly, the wider tunnels, even if the tunnels become wide, according to literature, it does not have any effect on the clinical outcome, but certainly will have problems, especially if you're doing a revision. So these are generally the advantages and disadvantages. So interference screws, despite the fact that there may be that, but again, we have got problems with the graft damage, especially with the cancerous screw fixation, while the suspensory, we have got problems with the graft tunnel movement, the wind viper effect, and the tunnel widening. Now, the canal widening can also occur on the tibial side, even if in the presence of interference screws, and not so much on the femoral side in cases of the screws. Now, let's look what's happening throughout the world. So this was an article which was published in Askar's journal, and actually they interviewed, I think, so about 2,500 to about 3,000 sports surgeons internationally, and actually they actually tried to find out what they were doing, right from what the type of implant they're using, what sort of graft they're using. What I picked up the point which is related to the fixation. So look at the fixation. So the first was the femoral fixation of both the, and so this was that was basically done in 2020 and was, I think, published in the start of this year. And actually they looked at the femoral fixation, and this was sort of a survey of not what the ideal is, but what is being used throughout the world. So the femoral fixation of the hamstring, so the ICOS study, that was an international study involving about 2,500. So actually they found that 82% generally in the femoral side of the hamstring, they use cortical screws, while in the BTB, roughly about that amount, they use the metallic screws. Again, on the tibial fixation, again, on the hamstring, 62% will use bioabsorbable screws, and it's only in New Zealand where they will use, majority of them will use cortical screws. Again, on the tibial fixation of the BTB, majority of the people around the world, roughly about more than 90% will use metallic screws, evenly spread between metallic and bioabsorbable. And this was a study from the Scandinavian Knee Ligament Registry, and it basically shows you the increased trend in the use of, and these are basically for the soft tissue grafts. So femoral fixation, we can actually see it is the graft sort of is going up, And on the tibial side, we actually see majority of the people tend to use, the green one is interference screws, so there is increase in the use of interference screws. I also looked at the Swedish knee ligament registry, and this is the one I could find where actually they correlated the revision rate with the type of fixation. So for the BTP graph, if on the tibial side, if you use a cortical fixation, then the revision rate was about 3.5%, while if you use interference screws, the revision rate was roughly about 5%. On the patellar tendon graft, on the femur side, if you use cortical fixation, then the revision rate was 4.3%, and if you use interference screws in the BTB, then the revision rate was 5%, which I must say is generally opposite what we all do, on which we all think, but it may be just because of the reason that the number are not that huge, but actually they showed increased revision rate in the BTB if you're using interference screws. Again, on the hamstring side, so if you're using a cortical fixation on the tibial side, then the revision rate is 5.8%, and if you're using interference screws, then the revision is about 5%. And on the femur side, if you're using cortical, then the revision rate is 5.7%, but if you are using the interference screws, so it's 6.9%. So this is a sort of a big, I will say surprising, because majority of the people around the world, they use interference use for the, on the tibial side. This is again looking at the Scandinavian registry, and again, actually it shows in the endo button, the revision rate on the femur side is more as compared to the interference screw. So the question always remains whether you have to use an aperture fixation or a cortical fixation, and whether you should use biabsorbable or metal. And actually, the Cochrane also tried to find out, and also they designed a study in 2018, but it was withdrawn because they could not make any progress. Generally speaking, for the patellar tendon, probably cortical fixation on both sides, if you go by the Swedish joint registry, but the general trend is to use interference screw on both sides and tend to give better results. For the soft tissue graft, literature also supports that you use cortical fixation on the femur side or interference screw on the tibial side, and generally metallic titanium interference screws tend to be better as compared to the biabsorbable screws. So in summary, fixation is the weakest link, and current data gives mixed messages. Trends are different across the world, and fixation may depend on surgeon preferences and patient characteristics. Ideal choice may be to use both at the same size, especially in high demand patients, like use cortical plus interference screws on both sides. And in osteoporotic bones, cortical fixation may be preferable. So thank you.
Thank you, Dr. Askar.